Are there types of glaucoma the iStent Inject works best for? How is the iStent Inject advantageous over other non-device MIGS options? How do the results between iStent and iStent Inject compare? Get ready to find out.
Hello, and welcome to the Eye Glaucoma YouTube channel. My name is Dr. Constance Okeke. Did you follow with us through the 4-part series of iStent Inject? If you did not, click on the card for access to those 4 short videos packed with great information on the what, where, why, how, and in who of iStent Inject. If you did, thanks for watching MIGS University, and thanks for those who communicated with me with questions that inspired this video on preoperative frequently asked questions on iStent Inject. With that being said, let's dive in. So first up, are there types of glaucoma that you feel that iStent Inject works best for? Well, the device was studied and improved in patients who had mild to moderate primary open-angle glaucoma. I am a firm believer in aiming for proper patient selection to gain excellent outcomes. Secondary glaucomas like pseudoexfoliation or pigment dispersion were excluded in the pivotal trials. There are a few studies that look at some of the secondary glaucomas with iStent Inject, but none that are really substantial. So those who have had the best outcomes in my hands with iStent Inject are patients with primary open-angle glaucoma on 1 to 3 medications with more mild than moderate visual field loss that are fairly well controlled with the goal to reduce medications and typically maintain IOP. In many instances, I've seen that the IOP can be lowered further and I can also reduce medications, but I do tend to avoid patients who are with more uncontrolled IOP already on, say, 3+ medications like a PJ and a fixed combo and maybe another one, and who are on the more moderate to severe side of open-angle glaucoma. However, I do think that there is a niche for iStent Inject in patients who have an increased risk for bleeding, such as patients on chronic blood thinners for medical treatment that is mandatory to continue, or people who easily bruise. I have found very minimal bleeding with this procedure and to date have not seen any post-operative hyphemas. I do make effort to reduce or stop blood thinners, including baby aspirin, fish oil, and vitamin E, prior to any MIGS surgery to avoid this. However, if a patient cannot come off blood thinners, I still feel very comfortable performing iStent Inject the procedure. Another niche for iStent Inject, in my opinion, is in patients who are getting advanced technology intraocular lenses. Those patients who fit the criteria for glaucoma as I described above, I try to offer a premium experience, which includes, in addition to IOP lowering efficacy, a very smooth post-operative healing process and fast visual recovery. I find very minimal inflammation with iStent Inject cataract combinations and a very typically smooth, quick healing experience for the patient. How is the iStent Inject advantageous over other MIGS options that don't leave a device in the eye? Well, one advantage is its minimal trauma to the tissue, which aids in fast recovery, low PAS or peripheral anterior synechii formation, and low hyphema risk. Bleeding is very common and expected in procedures like goniotomy or trabeculotomy that do not leave a device in the eye. With iStent Inject, bleeding can also be present intraoperatively as a good sign of proper insertion and positioning of the stent, but the bleeding is typically very minimal. Excessive bleeding postoperatively can prolong visual recovery and promotes wound healing such that the angle structures can scar and PAS formation can occur. With the iStent Inject, there is little damage to the ocular structures, and the approach attempts to be as gentle to the tissue as possible. In the U.S. pivotal trials at 24 months, iStent Inject had only 1.8 peripheral anterior synechii at 24 months, which is quite low. Another advantage of the iStent Inject is that it provides a stable opening to outflow with a well-tolerated conventional metal material. The iStent Inject device is made of titanium alloy, and it's made without nickel. Placed in the proper position in the trabecular meshwork, the iStent Inject can act and remain as a stable conduit for aqueous fluid to flow more freely as it bypasses the TM, with access to multiple collector channels. Some non-device MIGS can be more susceptible to areas of closure if scarring or PAS occur. Another advantage is the iStent Inject's high safety profile and long-term efficacy data. iStent and iStent Inject have been well reported in the literature, with actually well over 100 publications on both their efficacy and safety profile with longevity. This is an advantage over some MIGS procedures that have limited clinical reported evidence. Also, iStent Inject has the lowest reported rates of significant endothelial cell loss, which has been seen to be comparable to phacoemulsification alone. Should I abandon the iStent first generation altogether and switch to iStent Inject? How do you think the results from the iStent Inject compare to those with the first generation iStent only? Well, I personally have made that switch to only use iStent Inject in those patients that formerly I would have been candidates for iStent only. I do feel that my eye pressure lowering has been improved with the iStent Inject compared to when I was just using the iStent first generation. And there actually have been a number of post-market retrospective studies, mostly overseas, that have shown that the iStent Inject has better outcomes with eye pressure lowering on less medications compared with the first generation iStent. And in these real-world studies, there's been a range of IOP lowering of 13.1 to 16 millimeters of mercury for postoperative mean unmedicated IOPs. And also in the iStent Inject pivotal trial, they had shown that the postoperative mean medication-free IOP was 17.1 millimeters of mercury. And that actually happens to be the lowest of any trabecular bypass MIGS pivotal trial number for IOP. None other has been lower than that. So I do admit that I tend to use more iStent Inject in my patients who have more moderate glaucoma, as opposed to when I was using the first generation iStent. I really did stay with just really mild patients because I wanted them to have excellent outcomes. But now I can expand that and utilize it in more of my patient population. Now here's a real example that I'd like to share with you of a patient that I used the iStent Inject in, and these are real outcomes. So I had a 71-year-old male patient of mine who was on 3 medications to control his primary open-angle glaucoma. He was on brimonidine, latanoprost, and timolol. Now his IOP at the time was 11 in the right eye, 12 in the left eye, and his cup-to ratio was 0.7 in the right and 0.65 in the left. He had a central corneal thickness of 539 in the right and 550 in the left. He also had a visually significant cataract that had a BAT of 2070 visual acuity in the right eye and 2050 in the left. His visual field showed a very mild borderline inferior arcuate in the right eye and an inferior arcuate, an early one into a nasal step in the left. His OCT of the retinal nerve fiber layer showed some inferior temporal and superior temporal thinning in the right eye, and then in the left eye there was thinning infratemporal, temporal, and superior temporal. So I decided that he was a good candidate for a combined procedure with MIGS, a cataract MIGS procedure, and I signed him up at the time for a CyPass with standard cataract surgery for both eyes. He did well with the first eye, And then he had improved vision, lowered eye pressure, and he did reduce a number of his drops with the first eye, which was the left eye. Then the CyPass was taken off the market, so I had to switch him to another procedure, and I chose to do the iStent Inject in the right eye. He did great post-operatively with great vision, a lower eye pressure, and less drops, with an even faster recovery in terms of less inflammation. So now, at 12 months post-surgery, his best corrected vision is 20/20 in both eyes. His eye pressure is 10 in the right eye, 12 in the left eye on just lantanoprost alone, and the patient's last words were, "I think I'm doing wonderful." Now, I was really impressed with the iStent Inject. To have a patient off of 2 medicines and an even lower IOP was a great result. Hey, we'd like to hear from you. What have your results been with iStent Inject? Have they been similar, different, maybe not tried it yet? Please make a comment in the box below with your answer, or take this short quiz in the card and let us know your thoughts. Okay, did you stick with me the whole way? Awesome. And if you want to know what to do if you insert the iStent Inject incorrectly in the OR, or what to do if you still can't get a patient to target pressure after the procedure has been completed, stay tuned for the next 2 supplemental videos on the iStent Inject intraoperative and postoperative frequently asked questions of MIGS University. Hey, if you like the video, please like and share the video. We'd love comments, questions, and feedback also. If you don't want to miss the next video, please subscribe to Eye Glaucoma and click on the bell to be notified when it comes out. Thanks for watching Eye Glaucoma YouTube channel, a place where glaucoma innovation is made easy for eye care professionals.